the body since last 6 to 7 months and loose stool since 4 days prior to admission. Generalized swelling. Generalized swelling all over the body.
All over the body 6, 7 months. And what we want to ask. Oh, sorry. You have been only this and ask relevant questions, negative and positive history. Do you want to ask anything? And why? Anybody? There are several things that may be passing through your mind, and on the history you want to elaborate. So one possibility, the first possibility that comes to mind, it must be nephrotic. Is there persecution? So then what questions do you want to ask? Yeah, what was the mode of onset? It was the first at the site of, and why do you want to know where it was?
So usually, if it is renal edema,
Yeah,
then
it starts with.
to start from around the eyes, periorbital, and then the legs, and then the abdomen.
Yeah. Then what do you want to know? So most probably renal edema. Then you want to know waxing and waning. It has been there sometimes or it has not been there
I
sometimes.
think the most common think of the way you think is 6, 7 year old, no? Which 6, 7 year old you have seen with generalized swelling? Don't ask every question that can come with generalized swelling. 6, 7 years. Okay. Could it be simply nutritional? Kwashiorkor,
Less
what's your
likely.
comment?
Earlier age of presentation in case of this protein energy malnutrition like kwashiorkor.
A 6, 7 year old with protein calorie malnutrition presents with generalized edema. That's my question. Well, in medicine, anything will happen. Have you seen anything? Now you're close to spending 2 years plus in pediatrics. And you must have seen few thousands patients by now. Okay. So use that to start discussion.
Is it possible? Nutritional, not likely. They are all
Why
one or
not?
two.
Why not? Malnutrition is common in every age.
Several reasons. Why not? Not just one.
Malnutrition may be common at this age, but it's always secondary. So the story starts with something else and then the issue. So there's no question, no primary. Okay.
So
That's 6, 7 years. He's not the only one who's going to talk, and not me also only one going to talk.
Nephritic syndrome.
okay. You mean acute nephritis?
Nephritis.
Acute nephritis presenting with gross edema
But
going
only
on
6
for
to 7
6, 7 months
months.
is unlikely. Means microscopically it can be nephritis, but macroscopically no. Pardon me?
Congestive heart failure.
Congestive heart failure. So what would you like? 6 to 7 months congestive heart failure in a 6-year-old child. What could be the possibility? What is the cause of congestive cardiac failure in 6-year-old child? Maybe some cardiac disease, long-standing cardiac disease, either acquired or congenital. But will it remain for 6 months with edema? Will the cardiac failure persist for 6 months? No. It must have been treated much earlier. And if he has persisted, that means he's largely decompensated and must have been rather bad. And maybe 1 or 2 questions, is he breathless? Does he have any exertional dyspnea? Is all that you need to ask. So cardiac less likely. Nutritional we saw is less likely. Can it be hepatic? That can also go on for 5, 6 months. The disease may not be very easily amenable to treatment.
Other stigmata like jaundice.
Okay, but we don't know now. So far, we have not gone to that. Usually, you know that If it is started here, then it may be starting elsewhere on the body. And also maybe in a hepatic thing, it is likely to be associated with ascites also, because it may not be only hypoproteinemia, but often it's likely to be. So prominent abdomen will also be there apart from pedal enema. So we are ruled out 3, 4 important causes of generalized edema going on for 5 to 6 months, probably in an otherwise normal child who is 6 to 7 years. That's all. This is just a
So
tickling for
those
thinking,
last
nothing more.
words need to be confirmed. That is very important. That was this child absolutely all right before this? Otherwise, your thinking will change, right? So that is very, very important. So all the secondary malnutrition due to any disease would come at this age due to a systemic disease, but then he will not be all right before that. So you'll have to check on that, right?
And I think moment you say generalized, it means that there is edema at more than one site. It could be two sites only. But let's believe that it's generalized. Okay. Now, when you take two sites, there are many possibilities. So the first question is how generalized it is. The typical generalized, that means both feet, both hands, face, even abdomen maybe. That is generalized in front of our eyes, and that's only the renal disorders and only the nephrotic syndrome. Nobody else. But that generalized may not mean all over. If it could be only the face, periorbital, and mild edema of the legs. In which case it could be any. But then there is no breathlessness. So can it be CCF? You have a facial edema, periorbital, and you have a edema of the feet. Only two places. Let's imagine that. Could it be CCF? So does CCF cause breathlessness? That's my question. And if it is a slowly progressive right-sided failure, then there is no significant breathlessness. There may be a cough because of pulmonary congestion, but not breathless. The breathlessness comes on the right side much later. The left side starts with breathlessness. So could it be a CCF if it's only two? Malnutrition, we said secondary, so we don't have any. What he said, has it been completely all right or not? That's very important. Then could it be liver? If you look at swelling at two sides, the liver comes first. Because typically swelling over the feet, abdomen. So liver comes first by priority. If it's all over, renal comes first. C-shape, rare. Nutrition, secondary. So again, not only with this. So these are the four causes largely about it.
And let us exaggerate the last line which I said, lose motions for 3 to 4 days, and let us say recurrent lose motions for a long time. With a stretch of imagination, maybe protein losing enteropathy, which we often don't think of. Yeah, so here, so that is why it is not there.
So which of the generalized edema we talked about should have 4 days of loose stools? Well, it could be something unrelated, but how do you relate the loose stool? Can a nephrotic have a loose stool? Can a cirrhosis have a loose stool? Can a C-shape has a loose stool? Which one of these could have loose stools related to this?
One second. All of you nodded nephrotic can have. Why? How?
Nephrotic usually precipitates in acute infection. Erythema.
Nephrotics have gut edema also, so absorption won't happen. Then we'll have loose stool.
So good. Infection, you're right, but then infection should be the starting point, right? Here it is after the edema has come, right? Oh, fine. Come, go ahead with the history.
The child was apparently all right 7 months back when the mother noticed abdominal distension, which was insidious in onset, gradually progressive in nature, uniformly involving all the quadrants. This was followed by swelling of the bilateral lower limbs, gradually progressive till knee. It was pitting type. There was associated facial and periorbital puffiness, which was maximum in the morning and reduced as the day progressed. Associated with restricted daily activity due to swelling, but the child was active and feeding well otherwise. Child developed loose stools 4 days prior to admission and 3 to 4 days per day. Watery in consistency, large in quantity, associated with worms in stools, and not associated with any abdominal pain. Not associated with mucus or blood in stools. The swelling has worsened in the last 4 days prior to admission as child developed loose stools.
So the first event as per this history is mother noticed abdominal distension 7 months back. Okay. So now, as we always discuss, suppose we were there at that time and they came to us with abdominal distension, what would we think of and what would we look for?
So the four F's of abdominal distension, like flatus, feces, fluid, this all we need to rule out.
So flatus and feces can be ruled out with one important question. What is that question? On history.
Constipation, vomiting.
Constipation, half the children don't know that they are constipated. Waxing and waning distension. Okay. So any distension which usually goes up and down is either flatus or feces. So you ruled out. So you're left with
Fluid,
and
fat,
fat. Okay. And
female.
organomegaly. No.
Organomegaly, yes.
Okay. So now go ahead.
For fluid, and the relevant history, uniform distension of the abdomen. This could be one.
Okay. So here it is uniform distension of the abdomen. Right.
Yes.
So then does it, if it tells you fluid, then this child has started with gradual progressive fluid accumulation in the abdomen. So what will be your thoughts?
Other associated features like jaundice, pedal edema.
No. So as sir told you a while ago, think first, can a child start with just fluid in the abdomen and it can go on increasing
sir.
gradually? If yes, in what condition? If no, then you will have to go back, no? And see ki what was missed, after which this fluid accumulation occurred.
So any preceding symptoms were there or not?
Correct. But is there any situation where you could have only fluid accumulation in the abdomen, gradually progressive, with nothing else?
So intestinal TB, but then
Intestinal TB. What are the, if I ask you ulta, textbook symptoms of intestinal TB? Start.
Fever, history of weight loss.
Go on, more. Fever, history of weight loss is any TB anywhere in the body.
Abdominal pain,
And,
bleeding per rectum.
and,
Obst-
so obstruction is a
Obstruction.
symptom.
Constipation or
Now you have
abdominal
named
pain.
7 symptoms. You have not named abdominal distension progressive in that. So what I'm trying to say is progressive abdominal distension is not your chief complaint of intestinal TB. It will come somewhere lower down, right? Okay. So which other situation you can get fluid? You said generalized fluid.
The hypertension.
Correct, but which is secondary, not first fluid, no? So one very benign condition which looks like ascites, but which
Pseudoascites in any carcinoma of the
okay, carcinoma is a condition where there will be many other symptoms. But you're right, pseudoascites. So what is pseudoascites? Cyst, a large cyst. Okay, and rarely tuberculous peritonitis may come with progressive abdominal distension and fluid, right? Most, so barring these, all other fluid accumulation will be secondary to something. So then you have to trace backwards. Okay, have you missed something here?
I think fluid accumulation anywhere, we are talking about abdomen, but anywhere, is the result of a balance between a plasma protein's osmotic pressure and the capillary permeability and the capillary pressure. In the abdomen, a portal hypertension. What is this important to understand is such changes don't take a long time. They take a very small time. So they could occur within few weeks at the most, never months. So I can understand a portal hypertension ascites starting, but to start with, the parents cannot notice it. When it becomes large, they would say, "Oh, last week only we saw that." That is the way we start looking at. If it's 6, 7 months, it cannot be fluid at all. That is out, even if it's generalized. And therefore, it has to be organomegaly. Gradually progressive for 6, 7 months, fluid is out. Okay. Fluid can accumulate acutely. Okay. Can I have an acute onset of edema, feet, and puffiness of face? Acute onset. Of course, kidney. What else? Capillary leak. 3 factors, no? One, intravascular pressure, osmotic pressure, okay, driving it out, and the capillary permeability. So most of them are acute. Some of them may look like over few days or weeks, but this cannot be. So it has to be organomegaly only. What organomegaly? Liver definitely plus minus spleen. So we already got first liver spleen till proved otherwise. No jaundice, etc. are out now. We are not going to talk about at your level, no jaundice, so no liver disease. Okay, jaundice can be without liver disease, and liver disease can be without jaundice. So don't bring jaundice in discussion. So then very likely that. And then of course bilateral lower limbs, okay, pitting edema associated with facial periorbital, yes, all that is talking about the same. Restricted daily activity, yes. Develop loose stools. We talked about it. She said that loose stools may be that. So everything looks all right and not associated with. So we got out of this slide a liver spleen to come up. What did we say earlier in the first slide? 6 year with edema at two sides is liver more likely. If it is all over, kidney more likely. Okay. By simple commonness, you would have said, I bet it's liver.
Now, of course, as time passes, you have to learn to take the history properly. So, this whole analysis of Sir is based on gradual progression over 6, 7 months. Now, if that itself you have got a wrong history, then everything gets fired, right? And similarly, that generalized versus upper abdomen also. See, many times we have told you that don't ask leading questions. So for very crucial questions, your question should be open. Now here if you ask, अच्छा पूरा पेट फूल गया था, he just has an option, he or she has an option of saying yes or no. They may just choose to say yes. So you are misled, right? So you have to ask किधर सूजन था. Leave it open. Then they will tell you ऊपर था, पूरा था, whatever, right? So these two things can make a lot of difference to your analysis, which part is right or wrong. Okay, fine. And so my question was that you said that 7 months that all this happened, and then suddenly you come to loose stools 4 days prior to admission. So all these 7 months, this thing is same. So
The abdominal distension gradually progressed till 1 month, and then it was same throughout the last 6 months. And then he did not sought any medical attention for the same. And then he has developed pedal edema and facial edema. And after that, he went to the doctor. Like, he went.
correct, but pedal edema is so 7 months back story started. 1 month abdominal distension, then pedal edema. So pedal edema is same for last 6 months. And when did the facial puffiness come?
Facial puffiness comes every 3 to 4 days and comes in the morning hours and then reduces as the day progresses. Every 3 to 4 days.
And this is going on for last 5 6 months. It's quite unusual. I think there is some gap in the history, but let's see. Okay, because it can't just stay that way all along.
And what he's trying to stress is every symptom, origin, duration, progress. Every symptom. Abdominal distension, what is duration, progress? Then facial edema, what is duration, progress? Unless you ask all those details, history cannot give you a diagnosis. And if you miss it, then even the test will not give you a diagnosis. So I think that is important to learn, right?
Child was admitted in outside hospital for the same for 9 days, and some investigations were done, and loose stools gradually resolved. There, the child received blood transfusion, and some oral and IV medications were started with minimal or no improvement. So, child was brought to our hospital. There was no history of any yellowish discoloration or pruritus or pale colored stools. No history of any reduced appetite or hematemesis or melena. No history of any decreased urine output, altered colored urine, or hematuria. No history of altered bowel habits, loose stools, bulky foul smelling stools. No history of breathlessness, cough, palpitations, or easy fatigability. And no history of any COX or COX contact. No history of fever, rashes, or joint pain or swelling.
Why does he receive blood transfusion? So which liver plus minus spleen needs a blood transfusion? To begin with, in the first slide, we said it must be liver and or spleen. Okay, not ascites. Ascites may be in addition, we don't know. But liver and spleen, probably. Which one of them needs? Does the liver disease need transfusion? Does the kidney disease need transfusion?
Chronic kidney diseases need transfusion.
So liver disease will need transfusion if there is a hematemesis or a black colored stool, so loss of blood. So when you need a blood transfusion, it's a hematological problem. Primary, secondary, forget. So could it be simply an hemolytic anemia we are discussing? 7 8 months, gradual, progressive, liver and spleen, typical. And now blood transfusion. Okay. What's your take on that? You must have seen all hemolytic anemias. Okay. They come for transfusion. They have abdominal distension. They have liver and spleen. That's what we are talking about, no?
Varieties.
Jaundice. Hemolysis to occur. Jaundice should be there. There is no.
Thalassemia has jaundice. So why hemolytic anemia must have a jaundice? You wanted to say something. There is a mic.
Early presentation. 6 years is still late.
So let me put you a question the other way. Which 6-year-old comes for the first time with severe anemia, with liver and spleen? We are imagining all this. We may not be right when we examine. We have no liver, no spleen, that is all right. 6-year-old coming for the first time for a blood transfusion has the liver and spleen.
Any acute infection, like any complicated malaria, they can come.
Have been fever and all. But you are right. Yes. Anything else?
Phagocytosis.
And therefore you would have said storage disorder first. Okay. Liver and spleen, getting into the bone marrow. Okay. Osteopetrosis. Liver and spleen, bone marrow infiltration. So any storage, that would have been the first cause. Okay. But in that case, the story doesn't start at 7 years. So there is something going different when we talk about.
And even in that between, like we said, that all 6 months remaining same was also funny. So something is being missed here. So that would not be the pattern of even a liver disease or a kidney disease for that matter. That you just have the same degree of edema for 6 months and a little puffiness coming up and down, right?
The only thing is, any chronic disorder going on for a long time may have an aggravation of the deficiency anemia to become reasonably severe for a blood transfusion. So, dual pathology, which is common in our country, everybody has a moderate anemia, 8, 9, and then he gets chronic illness, it becomes 6, 7, and somebody says you are severely anemic, you get a transfusion.
There is no significant past history. ANC history-wise uneventful. Birth history-wise full-term normal vaginal delivery. Cried immediately after birth. There's a history of neonatal jaundice on day of life 3 and discharge after receiving phototherapy for 3 days. Immunization till 3.5 months of age as per NIS protocol and developmental history appropriate for the age. This is the dietary history. The child is taking enough total calories and the total proteins are also enough for the age. And this is the family history. Uh, so the 6-year-old male child presenting with complaints of generalized swelling all over the body since 7 months and loose stool since last 4 days, which is developmentally appropriate for the age with partially immunized status, is most probably a case of anasarc under evaluation to rule out protein losing enteropathy, second nephrotic syndrome, lymphangiectasia, or chronic liver disease.
Can you just justify each of the diagnosis, why you have considered it? Positive and negative points both.
Uh, Protein losing enteropathy, because the symptoms are uh, there for 6 to 7 months, and the diet is actually very good. There is a something problem with the absorption. He's taking enough calories. The mother is saying he's taking 5 out of 7 food groups. He's taking protein in enough quantity. He's eating 2 to 3 eggs per day. Actually, we have seen him eating eggs, 2 to 3 eggs per day, and that's why protein losing enteropathy was my first DD.
We'll wait here and discuss this. So, your comments on what he said. I mean, he has his reasons, but let's think further. So, 2, 3 things to be thought of. First of all, if it is protein losing enteropathy, where is he losing protein?
Gut.
Through the gut. So, do we have symptoms of losing through the gut prior to the onset of edema? No. So,
No,
that
that
is
is
one important point. Okay. Now, the second thing is, why should that, suppose there is protein losing enteropathy, why is the gut losing protein? What is happening in the gut?
there was
Why is it not there? Inflammation. So, if there is inflammation, then will he have a good appetite? So usually any GI losses, like any malabsorption, who have a good appetite are the ones who are congenitally enzyme deficient children, not the ones who have inflammation as the cause of their malabsorption. So these two things you have to keep in mind.
I think a gradually progressive abdominal distension is not protein losing enteropathy. Okay, I imagine enteropathy may not have loose stools for you to see. Loose stools are largely carbohydrate malabsorption. Okay, frothy stools, all that. Also fat malabsorption, large stool, whitish stool, grayish white stools. But the protein malnutrition may not necessarily be picked up easily by intestinal symptoms. But the abdominal distension is not of the kind 6-7 months progressive slowly. Can there be a liver and spleen in protein losing? No. Can there be an ascites in protein losing? Yes, but at the far end. That means the story of abdominal distension comes much later, and this is progressive. So that's quite against the protein losing. Now, if you have proved it protein losing, then the history is not right. So let's not go by that. Once in one of this clinic, we had a Wilson's disease without hepatomegaly. Okay. So either the person said there was a large liver, but he said no palpable. But don't go by the thing. We have seen once Wilson's without liver. So we will have to look at that. So probably based on what you have given us, protein losing enteropathy looks less likely. So it looks like nephrotic, but this did not look like nephrotic. Nephrotic doesn't come with abdominal.
So let them. So you tell us your reasons for nephrotic, and then we'll discuss if anybody has against nephrotic.
Uh,
Come on, he's your friend.
We are learning all in the same. At the end, we may be proved wrong, so don't worry about that.
Yeah, yeah. So one of you must decide.
Abdominal distension for 6 to 7 months is a very long history for a nephrotic syndrome, and 6 years age also is not favoring nephrotic syndrome. But and periorbital puffiness is decreasing and it is positionally changing. It is possible.
So first of all, if it is right, then as sir said, you can't have a gradual progression. Your nephrotics, this becomes 0 to 100 in how many days? 100 means I mean fully swollen nephrotic. They become from no edema to fully swollen edema in what? 5 days, 10 days, 15 days, whatever, not 7 months. So that is one point. And then just exactly same all along is also not right. No? Yeah. Some complication would occur or something. So therefore, that is
Sure.
against nephrotic. What about lymphangiectasia? So now, yeah, go on.
There was bilateral limb edema, and that's why we thought one of my DDs is lymphangiectasia.
Yeah.
It doesn't.
So in fact, you're right, and means you're right means you should use one or two other things to defend it. Then we will see whether there's anything against. So tell me one or two things which are in favor of that. Favor of that as a principle. What point we said against protein losing, inflammation and appetite and all? What is your story here?
Hepatitis
Very
present.
good appetite and very good health otherwise. So if the child is otherwise absolutely normal, if that is a big if, then it may go in favor of something like a malformation and not a disease process like a liver disease, kidney disease, etc., etc. Right? So
A presence of puffiness of face and pitting edema, plus minus the abdominal distension. Pathologically, one thing looks very obvious that there is hypoalbuminemia as a cause of edema. It has come here, it has come on the legs. If it was and it has come probably over the abdomen if it has started. So most probably hypoalbuminemia is the underlying pathological cause in this particular child. Now, whether the hypoalbuminemia is as a nutritional, we thought it is less likely to be nutritional. So it is likely to be as a result of losing somewhere. Protein losing enteropathy may have lymphangiectasia or something as a cause, where they all are otherwise normal, a healthy child, but he is grossly edematous. They are not inflammatory disease, these are malformation. Only thing is they present rather early in the preschool period because of an existing malformation. So I was just wondering, okay, where can we fit in the protein, I mean hypoalbuminemia in this particular child and abdominal distension. Then the only thing that comes to your mind is hepatosplenomegaly with edema, because I thought that we have to explain our starting point should be hypoproteinemia or hypoalbuminemia. And then hypoalbuminemia, three commonest is either you are losing somewhere or you are not forming properly. If you are losing somewhere, you are either losing in the gut or the kidney, or if you are not forming it, then it is not nutritional. Then liver is the only thing. Cardiac we have ruled out. So again, it remains between these three.
I think typical lymphangiectasia is a child who is losing weight and becoming malnourished because he cannot tolerate fat. Okay, and therefore intestinal lymphangiectasia or spreading all over. There could be a pleural effusion, a pericardial effusion, whatever. But the hallmark is not growing well because fat is not getting tolerated. Okay, fat is not getting absorbed. And therefore, to me, lymphangiectasia is out because not that I've seen so many, but logic demands that they are malnourished, whatever else is happening. They have no reason to have a liver and spleen or ascites, generalized abdominal distension, but they are going downhill. They don't grow in height, they don't grow in weight.
Plus, sir, it will be localized. So here there's edema of the eyes and of the
Correct.
abdomen
Which,
and of.
which possibly over time nutrition comes, but abdominal distension for 6, 7 months, no. So to me, lymphangiectasia is also no. What about a chronic liver disease?
Uh, so there is synthetic functions have gone down, like hypoalbuminemia is there, and also the abdominal swelling. It could be a organomegaly, so it could be secondary to portal hypertension. So chronic liver
So
disease.
that is right. But have we got any symptoms to suggest chronic liver parenchymal disease? So lack of appetite, lack of weight, failure to thrive, lack of energy, not playing well nowadays.
No, child was all right over this 6 months.
So
Like
that is against a chronic liver disease, no? Because before it stops synthesizing albumin, it should start showing some of these, right? Okay. So fine. So we are just discussing all the angles. Let's go ahead and examine. The child is here.
yeah.
Okay, bring the child.
You can sit here for a while. Yeah.
to speak. Hello, what can you observe? Sick or not sick? Or in between?
In between.
Okay, in between. Ask for the mic.
Child is thin built, doesn't seem to be 6 year old.
The muscle mass also looks less only. And short stage. Yeah, she is pale. Abdomen looks distended. And
Want to comment on hair, or you just want to leave them like that?
lusterless. Yeah. And brown. Mm, brownish. And there is upper limb edema. Might be because of IV or can be the right upper limb edema. Dorsum of the
Lower limb also.
lower limb also.
So generalized. Puffiness is not as much. Do you think something to
There is
comment
no
on the
periorbital edema.
cheeks? Baggy? Do you think for all this nutritional thin limbs, etc., the cheek look little baggy?
Puffiness of skin.
Periorbital, no. But do you think the child is
Skin.
pale also?
Skin a little like shiny.
So now add everything. You said that growth wise doesn't look like a 6-year-old. You said muscles seem to be less, muscle mass seems to be less. So what is the interpretation of all
Chronic
this?
malnutrition. Chronic malnutrition.
Okay, chronic malnutrition is a very vague word. Now you have to speak better. And so what does it mean in this child?
Chronic disease.
I heard onset. So
Onset is quite early only, sir. By anthropometry, maybe we can guess the onset.
So one meaning is that either the onset is even before the symptoms, symptoms of 6 months history, but onset of disease before that. And the other meaning could be that it is a catabolic disease where you are losing lot of this. But there you wouldn't lose so much height. So if height is affected, then it has to be onset much earlier.
Absolutely. There, the lymphangiectasia comes up a little. Because the story is running for a long time. Okay, but the story of abdominal distension to start with, etc., may not be necessarily right. Again, when a lymphangiectasia patient has a very severe diet restrictions, if he keeps on eating well, he would have a lot of low stools. So again, we will have to look at the history.
Can abdominal distension be without accumulation of fluid? If the child is malnourished, the limbs are very hypotonic and also small, and the child has hypotonia of the abdominal wall, and therefore, can the child look to have a protuberant abdomen without accumulation of significant amount of fluid? So,
But
yeah, and it is there for some time. It is associated with
lymph
edema, and the things are waxing and waning. He's neither going down nor he has done better. So, a chronic disorder with growth failure, significant malnutrition, abdominal distension, which is neither disappearing nor improving. First 1 month it has progressed, and after that it has remained relatively stationary. The pathology has remained. So the situation has remained balanced, so to say, negative balance, but whatever he's losing, he's gaining. So ultimately, you may have to consider malnutrition as an important cause, and it can explain the anemia nutrition, as Sir said. All our children are to start with malnourished and I mean anemic to a certain extent that may have added. I think though we are not giving too much importance to that, the whole basis looks anemic and of a child with nutritional disorder. We if I imagine the kwashiorkor fellows, this is not the age, but the whole appearance, the pale, little baggy cheek, little alopecia, he may or may not have easy pluckability. And the edema is going on for such a long time without disturbing greatly. So somehow it is balanced. So maybe the main cause may be nutritional only going on for some time.
Secondary nutritional, not primary. So the result is malnutrition, but the cause is not nutrition. In fact, he says intake is very good. So it's not a nutritional disorder, it's a secondary malnutrition. That means something is not getting absorbed. So then, if that is so, now looking at a child, we zero down into protein losing or a lymphangiectasia. Both are losing, okay, in spite of eating, whereas the other will not really come into play. So now, with this shortness, we have a situation of much longer period of a disorder, probably hidden, probably missed, and therefore I think you have a protein losing and lymphangiectasia. Lymphangiectasia diet restriction, otherwise they go bad. So protein losing stands up now, and I can see your differential diagnosis is first protein losing. Okay. नुसतं बसायचं मराठी बोलताना भाई नुसतं बसायचं हा बाळा काही नाही करायचं आई आहे बरोबर नुसतं पोट आपण बघूया हा कमन somebody now talks about the abdomen आई आहे इथे, आई आहे ओके हा थोडं भाई असं वरती धरा थोडं. बस हा बस बस आणि हे वरती धरा हा.
In our child is in sitting position, comfortable. Hands and upper limb and lower limb thin. Abdominal distension present. Skin over abdomen is dry, normal and dry. Umbilicus everted, pushed down. Visible veins not dilated veins.
It has to be.
Mm. Mm. Mm.
Flanks are full.
Full. And umbilicus be like flat. Like that. Push down umbilicus only. Flat umbilicus. Flanks
Child.
full.
There is muscle wasting. We can see the intercostal spaces also
Ribs are visible.
wasting.
One of you palpate now and one of you tell us the interpretation of your findings.
Again, if you see the abdomen, the lower central part looks more prominent. Okay, you can see that. Okay, what is that then? If you're talking about simply an ascites with flank fullness, why is this part a bit swollen? Okay, you can certainly see it more prominent part of the abdominal distension. What that must be? Yes.
Intestines, because if there is horseshoe shape The fluid is accumulating around the intestines, in mesentery and intestine, forming the center.
So surely there is something possibly related to intestines. We don't know why is that, but take a note of that. And that's why we have an intestinal disorder looks like. Again, we are falling between those two. And let's see what more we get. So
This is not the distension of the organomegaly.
So one more doubt. So like if it is had it been loculated ascites, so sir, it wouldn't have been so generalized. It would have been like in one particular, so it would have been prominent.
Loculated ascites, first of all, is not very common. So, what do you mean by that? You're meaning a cyst or you're
Yes,
meaning
sir.
Yeah, cyst.
a localized cyst? So, localized cyst, when it is small, it doesn't present only as distension. And when it presents as distension, it's a sufficiently large cyst. So, depending on the findings, either you may find that it is more half on one half than the other. So, you may be able to make that out. Or you are not able to demonstrate shifting dullness. So, that will tell you that this is a big cyst, right? But here I don't think that is under consideration.
To see the abdomen, this side is not as prominent. This is prominent. Then coming down, then again coming. As if there is something under. This is also, it's not in the center. Look at this part and look at this part. On the left side, it is more prominent. Then there is something like a depression, and again it has come like that. So it's not, though it looked like a uniform abdomen, scanning it, it is not a this uniformly. It has some variations in different parts of the abdomen. So it will not be that typical ascites where it's all a generalized distension like that. There may be some, you may find some lump here and there.
काही नाही करत मी. माझ्याकडे सुई नाही आहे बघ. काय झालं तुला? On superficial palpation, there is no tenderness. On deep palpation, there is no organomegaly. No liver is palpable, no spleen is palpable.
Sir. So we'd like to demonstrate the shifting dullness. So if you could see the technique.
Horseshoe dullness है क्या?
Sir Joshi, sir, please most. Okay. Thank you. Sir.
सुई नाही मारत मी. Panic note is heard over the The tympanic node is elicited all over the abdomen. No dullness. Auscultation. There are no
Any organ,
no
any lump?
organomegaly.
Have you gone deep enough? Be little gentle. That side, on this side. प्रेम तुला काय हवं? There's no lumpy feeling this side. Yes. These are intestinal dilated.
When you saw that central part, you knew it was an intestinal, whether it was a gaseous distension or whatever the cause. And therefore, we have an intestinal disease. Now, settle between the two, protein losing or that looks like something that has been going on for a long time. Both can go on for a long time, but both may have a good appetite. But I feel that a lymphangiectasia has a lot of restriction of not taking too much of fat, with the result that if she has a good appetite, she would have diarrhea off and on. Whereas a protein losing enteropathy may not have necessarily a significant complaint of loose stools. As we said, carbohydrate and fat malabsorption have loose stools, but not necessarily protein losing. So to that extent, first diagnosis is a protein losing enteropathy, right? So that's where we stand on. Have you seen her with a lot of edema like nephrotic?
Actually, he has the edema like over the past 10 days, past 7 days. He was admitted in our on our side, so the edema is reduced right now. Actually, he had ascites also. On arrival, he had the horseshoe-shaped dullness, and we had
Horseshoe is, I'm sure we have not seen a horse, so we have not seen horseshoe also. That's, I think, imaginary. And
and
that's an ultrasound diagnosis. Ascites never disappears with your diuretic, just like that. So for us, clinically, no ascites. Okay, you might have said a little, but horseshoe is so difficult to pick up. That means you have to imagine there must be one. And when you imagine, when an ultrasound report is already seen by you, then your imagination is at the height. So horseshoe is okay. Okay, so that possibly not. And I think again the point is that either of the two don't have prominent ascites as a feature. Does Kwashiorkor have ascites? Severe hypoalbuminemia, severe hypoproteinemia. Does protein malnutrition come with ascites? The answer is almost never. Sheila Sherlock says rarely she has seen it in her book. Otherwise, there is no reason for ascites in a malnutrition, protein malnutrition. So there must be small amount of fluid, maybe. I can't. Well, if you are good at horseshoe, you might have picked it up. But
Not a presenting feature.
not a presenting feature. Okay. त्याचं पोट कधीपासून मोठं दिसतं तुम्हाला?
झालं 6-7 महिने.
त्याच्या अगोदर नव्हतं मोठं असं?
त्याच्या अगोदर कधीच नव्हतं.
ते मोठं होतं ते कधी कधी कमी वाटतं आणि कधी जास्ती वाटतं?
ते पोट त्या हिशोबानेच मोठं.
आणि ते हळूहळू वाढतंय का? का आहे तेवढंच आहे? हा, बरोबर. पोट तसंच राहील.
खेळायचा बंद केव्हापासून झाला?
जेव्हापासून त्याला सुजन आली.
आता नुसता बसून असतो.
नाही, आता पुऱ्या वॉर्ड मध्ये घुमतो, खेळतो.
वॉर्ड मध्ये यायच्या अगोदर
तेव्हा पण म्हणजे खेळत
घरी-
नव्हता. सुजनमुळे घरातच बसून असायचा.
summarize? Summary requires a little bit of extra skill. So let me attempt. Malnutrition, protein energy malnutrition, chronic protein energy malnutrition with anemia, maybe he has some chelosis, etc., long standing, waxing and waning, but secondary. So find out where the cause is. Probably the cause is somewhere in the abdomen only, either in the intestines, most probably. He's losing that. And though there may be no marked inflammation there, that gives rise to abdominal symptoms, but he's certainly losing some ventricularity. He's not losing it in kidney, and there's no hypoalbuminemia of synthetic variety. So he's losing somewhere in the intestine. So malnutrition, secondary malnutrition, protein energy malnutrition, secondary. Yes, growth failure also is going on. It's such a so maybe even to begin with, he may not have been a very well nourished child even in first few years of life.
I think it would be ideally called as malabsorption because this child is not absorbing proteins at all. Therefore, there are no signs of amino acid deficiencies. Kwashiorkor has an amino acid deficiencies, and therefore you have skin changes, hair changes, mental changes. This child did not have that because he is losing the whole protein itself. Whereas a typical kwashiorkor is an amino acid deficiency, which we call it as protein, but it's not a protein deficiency. Proteins are broken down, which is not happening properly, so amino acids are not formed. Here the proteins are not absorbed at all. And therefore it's a protein malabsorption and not strictly protein malnutrition, because severe protein malnutrition will have a lot of other things like kwashiorkor. So we'll call it a protein malabsorption, like a carbohydrate or fat malabsorption. And I think that's the first probability. Let's see what you have got.
Just quickly go through your findings fast, only the positive findings because you already examined. नहीं नहीं findings तो दे पहले. Whatever we have seen, yeah, in fact the height, weight. Okay, all this is fine. Go on. Next. Okay, wait. Height is 85 centimeters, which corresponds to what age? Two years. Very good. And this is a.
When did this problem start? At 2 years. Correct? Sure.
There was also very short.
Did it start at 2 years and then the height button got switched off?
Suddenly stop.
Huh?
So it must have started even earlier. Okay. And therefore, it must have started in the first year old. So that means it's born with the problem, but came to light much later, 6, 7 months ago. But till then, the growth nobody measured. Otherwise, growth only would have picked it up. Right?
Okay, now see how much these things can tell you. Look at the weight. We want you to start thinking 13.6 is at what age?
2.5.
3 years almost. So weight is better than height in a systemic disease. Why? So sir gave the answer. One is edema. Any other thoughts? So that's where what Khare sir said comes in, that a element of height could be constitutional. The mother was short. So start thinking like this. And we are not saying that height is not affected. Height is definitely affected. A 2-year-old height in a 6-year-old girl child is absolutely abnormal only. But when weight is better than height, you have to start thinking why. And these could be the reasons. Comment on BMI.
Here malnutrition, but BMI is all fine. What kind of BMI is that?
It's a ratio, weight in kg by height in meters. Hmm.
Since weight is good for that height, we are getting good BMI.
Yeah.
Mass.
So this is a erroneous thing because of the presence of clinical edema, right? And weight going up because of that.
If both height and weight are affected, so like should we label this as acute and chronic malnutrition or like
See, this word acute on chronic, you cannot decide based on only the numbers. You have to go by the
history as
clinical
well?
history and correlation.
The best term to use is stunted and wasted. So there is no question about anybody asking a question. He is stunted and he is wasted.
Okay.
Uh, there
Yeah,
is
I think we've seen all this. Go ahead.
systemic examination.
Fine. I think there also we have seen everything. Go ahead. Fine. Fine. So now tell us your final impression.
Uh, 6-year-old male child presenting with anasarca since last 7 months, loose stools for 4 days back prior to admission, with history of blood transfusion, with abdominal distension, with prominent veins, with bilateral pitting edema till knee, with facial and periorbital puffiness on admission. Who is developmentally appropriate for the age, partially immunized for the age, anthropometrically stunted and wasted, is most probably the case of anasarca under evaluation to rule out protein losing enteropathy.
So just for discussion's sake, why did you put veno-occlusive disease there? Means what was the thought process?
Actually, because of the investigations.
Okay. Fine. So tell us the investigation.
This is the LFT's progression. The total Billy OTPT is normal. The 11th, the yesterday's OTPTs are a little bit of on the higher side, 71 and 48. Total protein is 4.7, 5.2, and 4.9, and currently it's 6 after giving the high protein rich diet. Uh, and the albumin is right now 3.1. On presentation, it was 1.6 on 26th of February. And CBC, the HB was 7.1 and has received one blood transfusion outside on the HB of 7.1. Currently, it's 9.1 HB. Uh, urine RM pus cells were 8 to 10, with spot urine albumin was normal. Urinary protein UPCR ratio was 0.6, with 24-hour urinary protein was 59, which was normal. Stool routine microscopy was normal. Thyroid function test normal. PTNR was within normal limit. Cox work was done, which was also normal only. Uh, After that, ascitic tap was done, which was the clear fluid with 48 cells with all the lymphocytes, and the serum albumin to albumin ratio was 2.9. And hepatoportal Doppler was also done, in which the all the other findings are normal, but the portal vein was measuring 10 mm, which was dilated for the age. And USG abdos pelvis suggestive of moderate to gross ascites with edematous thickening of gallbladder.
Will you please interpret SAG? First, give the full form of SAG.
The serum albumin minus albumin, ascitic fluid albumin. It's the ratio of that albumin. It's a subtraction of the albumin, and it was 2.9, which was more than 1.1. So that's why we have also kept our DDs as post hepatic liver disease, chronic liver disease, or early stage of any chronic liver disease, or any veno-occlusive disease like early Budd-Chiari. Just this ratio. And the portal vein is also dilated.
I think SAG alone is not the reason why you start thinking it's the liver disease. Okay, clinically there is nothing of that kind. So why do you want to only pick up that SAG? You question the SAG and you say whether there is any abnormality in measuring the ascitic and the serum albumin. Okay.
And sir, one
So
point even beyond that. See, what is SAG? Serum albumin minus ascitic albumin gradient. So when SAG is high, what does it mean? Either serum albumin is high or ascitic albumin is low, right? Then SAG will be high. Serum albumin is never high. So therefore it is ascitic albumin low. So actually this just tells you this is a transudate, what we used to call in earlier days. Now transudate has multiple causes. So directly this doesn't take you to any particular etiology at all, right?
absolutely.
South inflammatory, abdominal inflammatory
Absolutely.
like cause like peritonitis.
Absolutely. Okay. So, and I mean, for veno-occlusive disease, ultimately the liver itself should have been abnormal in some way over a period of time, whether there would have been hepatomegaly or even your USG would have shown that the hepatic structure is different, right?
Echo texture is normal.
So seems less likely. I think
Just-
clinically, with almost intestines palpable, so to say, it has to be an intestinal disease only.
I think the problem in the evaluation of such test results is there must be a secondary hepatopathy because there is so much of chronic illness going on that the hepatic functions may not be fully normal. But that doesn't mean that it's a hepatic disease. So two things are a bit different. And to that extent, severe protein malnutrition will have every system involved, neurological system involved, myocardial system is involved. But you don't call it a myocardial disease or a neurological disease. So I think that small changes does not really mean that it's a primary liver problem that we are discussing.
And now you look at your own therapeutic action and the outcome. What have you done? You have given high protein diet and you say that the child has improved. Would that happen in a liver disease with veno-occlusive disease with portal hypertension? By giving a high protein diet, would your albumin come up and your ascites go down? No. So therefore, that is also against this, na? So this is some incidental finding. Incidental means it doesn't fit into the picture. So this is that classic example of correlate clinically.
What is the dietetic history of the child?
It's good, sir. Actually,
Before admission.
before admission also he used to take like in the breakfast he used to take dal chawal one bowl. Then in lunch used to take one chapati with dal and rice, one bowl. And also in breakfast he used to eat non-veg every alternate days. Like he used to eat non-veggies,
What non-veg? Egg.
mutton. Mother is saying he likes mutton very much. He used to.
So nutritionally, he has no reason to be nutritionally hypoproteinemic.
That's why I think, as Sir said, he has been losing. It is not that he's, intake is poor. So now, what will be the next step? How will you go ahead? Means we don't have a confirmed diagnosis now, na? So what will be the next step?
As he's also having short stature, we can look for celiac disease.
Correct. So you tell me what is the next step? What will you do? Others also can pitch in. So we'll do a liver biopsy. Shall we do a liver biopsy? No? Then what do you want to do?
Colonoscopy can be planned.
Some GI investigations, either colonoscopy, maybe even with a biopsy, intestinal biopsy, that is the immediate next step which will give us some idea rather and most likely yield of that investigation.
But all inflammatory diseases should have pain as an important. Chronic abdominal pain, going, you say Crohn's or whatever, they should have that which is absent. You treat him, you see how his protein comes up, and then you see whether he goes down at all. After having raised his diet and protein, then on the same diet, if he goes down, there's no second diagnosis that he's losing.
I think first thing we said, it started very early in infancy. So second is it's non-inflammatory. So what is it? It is a congenital problem of enzymatic absorption. And there you would just do a colonoscopy and, or an intestinal biopsy to prove that it's not inflammatory. But functional diagnosis cannot come with histopathology like this. And therefore, we will have to say that whenever there is a protein losing enteropathy, the differential diagnosis is it inflammatory or non-inflammatory? And if it's inflammatory, celiac or whatever, multiple things. But this is non-inflammatory. Why non-inflammatory? What is said, no pain, no, etc. PSR is 5, whatever. So non-inflammatory is a problem of a congenital enzymatic problem. Call it a metabolic error of the intestine. And you will not get anything out of biopsy, but biopsy will have a negative value that is not inflammatory.
So like celiac will also come more with this chronic diarrhea. So celiac could more come as a chronic diarrhea or recurrent loose stool.
See, the problem is inflammatory bowel disease may present with diarrhea, with constipation, without change in loose, but often on something happening intestinally. Whereas here, there is hardly any such story at all. So it's a enzyme problem of absorption. And I think that is the final diagnosis. It's not secondary. Protein losing enteropathy is a syndrome. And therefore, it's not a final diagnosis. But the cause of it may be congenital, metabolic problem.
Sir, may I describe one case of so-called protein-losing enteropathy I saw? A 2.5-year-old child presenting like a nephrotic syndrome, edema, happy child, playful. And when we ask the history of diet, is he taking milk? He says he takes 4 to 5 glasses of milk every day. What are you talking about nutrition? He looked happy. He was not diagnosed. He was sent. He came with secondary infection and acute peritonitis, and he passed away. Now, without telling the parents, we had a small incision and took a piece of intestine and sent them because they wouldn't. The family was Pelwan family, so they had not asked about autopsy. The final pathological, histopathological diagnosis was intestinal lymphangiectasis. Can I say something? Of course. Nivedita, 2 minutes time. Yeah. I'm going to tell you a story. There was a movie, Honey, I Shrunk the Kid. Anybody saw the movie? Heard of it? No. The machine shrinks the babies. We have shrunken our babies as a country. 1. 2. There is a nice novel, Alice in Wonderland. Anybody read about it? Read it. So you go there, you drink something, you become small. Then you drink something, you become tall. Average baby should be 3.3 kilos at birth. There was a 6-country study. India was one of them. Purohit from Nagpur Medical College was one of the party researcher. Global study. So the baby should be 3.3 kilos. We are so used to nano babies that we make 2.5 as good. So we create nano babies and we all are
Our genes are to make a 6.5 K, 6.6 boys, 6.3 girls. So what's wrong with this country? We starve our babies. If you just keep food in the corner, the rats eat and they grow. Indian houses you can describe fat rats and nano kids. That is Indian baby. Rats don't have to ask their mamas, so they grow well. So if you just keep food on the ground in the corner, are all children will malnutrition is a man-made problem. It is made by Indians, by the Indians, for the Indians, of the Indians. Who will change this? We are nano pediatricians talking to 5 people. 1 lakh babies are born daily. We treat 5 and we are happy. We make money and that's the end of it. Your college has a huge center, nutrition, blah, blah, blah. What is the impact on the country? Some impact, but not statistically significant. But we can make a statistically significant impact. We means you 20, 40, you're 40 people here, 100 people here. How many people, residents? 40, no? So now you guess. 40 of you and me, 41. We make 1 minute, one video on nutrition every morning before you come out of the washroom. Once you are out of the washroom, you have call, blah, blah, you have no time. So before you leave your place, in the first thing in the morning, you make a small 1 minute video on nutrition in your mother tongue. And in English and in Hindi and in Marathi, whatever. I operate in many languages. And just put it in social media. It will go across and change the country. Textbooks, a lot of knowledge, lakhs of doctors. India has no impact. But we can make a, you have a global university, video university, using media. Today we can, in 1 year, we can change the country. So I'm not asking you for your blood. I'm not asking you to go and give your life. Just make one video of social importance. But start with nutrition. Do it in English, do it in Hindi if you know, do it in your mother tongue, whatever languages you know. And we 40 people will change the country. On next Holi, when we meet here, India will be different. Anybody willing to join? This country is of non-performance. None of us do anything. We do nothing at all. We're a country of very bad country, bad people. So you can do this, no? Before you come out. No, nahi karoge. Nahi, suno na. Now, before you come out, now the whole country will be knowing you. Your examiners will be knowing you before, so you'll have passed before you appear. Honestly, I had a call from Modi's office yesterday morning. So Modi will notice it and he'll come to me. Who are these 40 guys who have changed the country? We can revolutionize this country. 40 of you decide about it. You take my number. So let's do it. Thank you.
8 years old female child, third by birth order, born out of non-consanguineous marriage, present with complaints of bleeding from nose since afternoon and bleeding from oral cavity since 2 days. Child was apparently all right 2 days back.
क्या हुआ? स्टॉप शेयर करके वापस शेयर कर.
Child was apparently all right 2 days back, after which mother noticed blood coming from child's oral cavity during sleep. Bleed was small in quantity, bright red in color, and result unknown. Next morning, child had similar episode of bleeding during sleep, which resolved spontaneously. The same afternoon, she started having nasal bleeding, moderate in quantity, with clots present. There was no history of trauma, no history of bleeding from any other sides, no history of fever. History of passage of black color stools. History of fever with rash 2 weeks back. Rash was fluid filled vesicles associated with itching. First appeared on trunk, followed by limbs. No history of any similar illnesses in past. Past history of one previous admission at 9 months of age for bronchopneumonia. ANC and birth was uneventful. Immunized till date. Developmentally age appropriate. Goes to school in third standard. Good scholastic performance.
So, what are your thoughts? Come on, anybody can speak. We are all here to learn. What do you think?
uh, 8-year-old female, and there is an acute history of bleeding from oral cavity and nose, and there is no history of trauma, but there is a history of infection, maybe chicken pox, 2 weeks back, and there must be a post-infectious.
So, does chickenpox have a complication which can lead to bleeding? Do we know of any such complication? So, by itself, what will you look at the bleeding? Keep the chickenpox aside for a while. What will you think of the bleeding? Bleeding from the nose and mouth. So, is it bleeding?
Mucosal bleeding.
Mucosal bleeding, and also she has some rashes. So platelet type of bleeding, spontaneous.
Spontaneous non-traumatic mucosal bleed, more favoring platelet rather than coagulation.
So, rashes were what? Chickenpox rashes, you were saying, no? Vesicular. They were not like petechial spots.
The 2 weeks back, she had fever. Uh, First rash appeared, then fever. The mother described rash with fluid-filled vesicles. First appear on trunk, then all over the body, associated with itching. Also, sibling has similar rash. Previously, sibling and then.
Oh, so that was chickenpox. That is done with. Now, after this bleeding, is there a different kind of a rash?
On exam, mother didn't complain, but on examination there was PTK.
So, clinically, one you said was mucosal bleeding. Now, you have to think of common things, even commoner than a bleeding disorder. So, you could have simple epistaxis, which is common in children, which is idiopathic. But what will you ask about that?
Sure.
Nose picking, usually past history. I mean, this may not be the first time, and things like that. Now, what is against, or what else did you notice from the history? Okay, bleeding from mouth meant what? It is two different sides of bleeding, or it swallowed blood. Again, you need to be, your history needs to be more clear on that.
There is clots in nasal bleed. If it's nasal peaking, then clots are not possible.
And there are black tarry stools, which means that the quantity of blood was significant if it was black tarry stools. So that's the other interpretation. Go on.
I think with these two things, one is not sure whether there are multiple areas involved. Even the nasal blood itself will come out of the mouth as well. So it may not be two sides, but that is the first thing that we want to confirm. Two sides make it the primary bleeding disorder, whereas one side could be local. And what local besides trauma? Anything local, only nose bleeding, local, but not a bleeding disorder.
Any nasal polyp.
Nasal polyp is unlikely to bleed. It might obstruct or whatever. So tell me the third cause of bleeding, besides the bleeding disorder, besides trauma.
Hypertension.
Hypertension in children rare because hypertension has to be a chronic process. But yes, hypertension could be caused. But now you have got an idea. What is hypertension? Where is the pathology of bleeding in hypertension? It's blood vessel, right? Now that's another clue. That's the other cause that you may have a vasculitis. And one of the vasculitis, like a Wegener's, may come with only hemature, only the nasal bleed. So you got a right point. It's a blood vessel, and inflammatory blood vessel will just bleed through the nose, right?
Survey at this age.
Scurvy usually gum bleeding, mouth bleeding, but not the nose. Yeah.
Examination child was febrile with pulse of 108 per minute, respiratory rate of 26 per minute, saturation maintained, BP was maintained within 50th percentile, pallor was present. On anthropometrically, child was severely thin, weight of 14.4 kg, height of 111 centimeter with BMI of 11.9.
Age 8 years.
Yes.
There is a pallor also. When there is a bleeding and pallor, it is not a bleeding disorder. Two cell lines are involved.
That is severe bleeding, then
But bleeding from the mouth, etc., is not like hematemesis, etc. Your point is right. You are trying to say that he is pale because he has bled so much. Nose cannot bleed so much to make you anemic.
So is there.
Internal bleeding for lengthy duration of time. Chronic.
To me, bicytopenia is always something dangerous. Okay. It may be a bone marrow disease, some infiltration. Okay. Yes. So what's your comment on that?
I'm giving you a clue.
And therefore, every bleeding disorder in India is also little pale because every one of us has deficiency anemia. Okay. And I literally remember people those days when we were students trained from abroad, they would say, no, I will do a bone marrow because there is a, but the pallor is mild. And who doesn't have a pallor? And because he has a deficiency anemia, you can't have no bleeding disorder, no. So that pallor is of no concern.
On head-to-toe examination, clots present in oral cavity, PTK present on upper and lower limbs, heel scab marks on abdomen. On systemic examination, per abdo examination soft, liver of 1 centimeter, spleen not palpable, rest of the systemic examination was within normal limit.
Child is here. Oh. So what's your final diagnosis?
Ma'am, sir, it could be a immune pathology due to underlying previous viral infection, which lead to some immune dysregulation, which lead to thrombocytopenia. And after the admission, the child have a severe episode of hematemesis, which led to the further deterioration in vitally stable child. Child also required intubation for the same because the sensorium was dropping and respiratory in view of respiratory distress.
So respiratory distress after the hematemesis.
Yes. Yes.
No. What is the sequence of events? Means
So
how
the child was admitted in the late night. So bleeding episodes when she was admitted in the ward, the bleeding episodes increased from the nose and the oral cavity. Then early morning she had a severe massive episode of hematemesis, very large quantity. After that the BP dropped and the pulses went feeble and the sensorium dropped. And child was also having a labored pattern of breathing.
So labored pattern of breathing here is just secondary to shock. It is primarily large volume of blood loss and shock, which has led to everything. Now, do you think the thrombocytopenia can do that? I find it a little odd that it should cause such a
So
large.
I think we will have to revise our thinking. We said that it must be a thrombocytopenic bleeding. But when there is a large hematemesis, that is not the cause. So the question is, what caused hematemesis? Could that cause a nasal bleed? We started with nasal bleed and we said it's an ITP. Okay. Now, if you look at varicella is, well, it's a viral infection. Anybody can do anything. Okay. But one has not seen, to begin with, ITP was called idiopathic thrombocytopenic purpura. Okay. Thereafter, they said, no, it is always some infection, but infection may not be visible, may not be having fever. So we call it immune mediated thrombocytopenic purpura. But varicella is not a common known cause of an ITP. So that starts worrying us. Then the question is, what could be the cause of? Suppose, forget this story at all, and this child has come with hematemesis. What must be the cause of hematemesis? Nothing else. Okay, like nasal bleed, he suddenly threw up a lot of blood in a vomit and he has come to in shock.
Varices.
What I said, 8-year-old, first time in life, no abdominal distension, on examination, no liver spleen, etc., etc. You are right. Varices is the commonest cause, but probably in absence of any physical findings, that is unlikely. Correct? Then what?
Extrahepatic portal venous obstruction.
There again, you should have got spleen and all little earlier age. No, Mallory Weiss cannot have such a big amount
It's any
of
malformation,
malformation,
arteriovenous malformation.
vascular malformation.
Vascular malformation. And it could be here too. Okay, so you go the other way around and not thrombocytopenia causing that. In fact, we were strongly considering that hematuria is never due to ITP. And I had not seen that till once we saw. And then we referred and they said, rarely it could be also that, but not massive bleed like this. So I think malformation is most likely. Could it be the point that we talked about, like Wegener's, some vasculitis there, here?
Causing this acute type of bleeding, which is very severe, that child is going in shock. We don't.
If the big blood vessel has been injured, you will lose a lot of blood. But the child would be very sick. This child became sick because of hematemesis, was not sick to begin with. So that's not possible.
Can it be von Willebrand's disease?
Female child.
This is so not possible. Possible. So then tell me whether it's von Willebrand's disease or not. Factor 8 and from platelets. So that's why such a large bleeding.
Consanguinity.
May not be there, no, difficult to, not always there. Petty will not be there. What else? Come on. Sion Hospital should be very strong in hematology.
Hematemesis
no hemarthrosis. Von Willebrand's is seen in adults as menorrhagia and nothing else. Do they have thrombocytopenia?
Usually not.
So they don't have a
Thrombocytopenia.
thrombocytopenia that is manifest. It
Hmm.
is usually a qualitative
Qualitative
defect
Hmm.
rather than a quantitative
Quantitative.
defect, right? Okay.
So, sir, on arrival, the child has a HB of 7.9 with platelet of 84. Post transfusion, the HB become 10.7, but the platelets was further dropping.
Okay.
Okay, go on. Anything else?
In LF, and transaminase were little deranged, but rest of the parameters were within the normal range.
Prothrombin time?
Sir, it was INR was 0.9,
PT.
11 point some.
And PTT?
It was also within normal range, sir.
Okay.
All other coagulation profile was within normal limit.
Okay. How is the child now?
She's stable, sir. We have given her IVIG by 1 gram per kg, and also transfused platelets, and MPS was also given in pulse doses. Now she's no recent episode of bleeding, no melena. She was having altered RT aspirate.
And what's the platelet count now?
2 lakh, nearly 2 lakh.
Okay. Fine. So I mean, as of now, it looks like it was isolated thrombocytopenia which led to this. It is again one of those rare situations, but if you go back and see in most of your ITPs, you'll never see hematomesis as a complaint, and that too such a big hematomesis to land you in shock, right?
So one doubt. So like in any case of thrombocytopenia, like in any cause, so the mean platelet volume will be increased, like compensatory wise.
Sir, you are not audible. Rajesh sir, you are not audible.
We cannot hear you, Rajesh.
Rajesh sir, we cannot hear you.
Audio.
Rajesh, we cannot hear. We cannot hear
We cannot
Rajesh.
hear you, sir.
We cannot hear you.
Switch on the mic. Switch on the mic.
Ma'am, I think mic should be on.
Mic. Must be mic
We
problem.
cannot hear Rajesh.
Rajesh sir, can you hear us? Ma'am, kindly
No,
call
I
him.
think I'll call Archana or Rajesh.
Yeah. Yeah, please, ma'am. Yeah, thank you. No, sir, no audio. No audio, sir. No, sir, we cannot hear you.
Rajesh, not audible. Rajesh. Not audible.
Rajesh sir, Rajesh sir?
Rajesh, we cannot hear. The mic is off.
Rajesh, audio. No, no audio, Rajesh. Okay.
Rajesh, we cannot hear you. We cannot hear anything, Rajesh. The mic is off.
Anjali, I told Rajesh by phone. I
Oh,
told
all
by
right.
phone already.
Okay,
But
okay,
he's checking
Palni.
it. Okay. Okay.
Can you hear us now?
Yes,
Yes,
yes. Now,
sir. Yes,
now,
sir.
Yeah.
yeah.
Yes, sir. You are
Yeah.
audible.
Yeah.
Yes.
So I think Palni, you made a comment that petty are against varices or malformation, and platelet count was not low enough to cause such a large bleeding. So I think that's what Sir is saying, that we are not comfortable explaining it only on thrombocytopenia. So whether there is a dual reason is what we were discussing. Any other inputs from anybody? Any comments either on the first case or this case? Anjali, Palni?
No, Rajesh, both cases were excellent.
Enjoyable learning. That's all. That's it.
Enjoyable.
Very enjoyable learning.
So I think we would like to thank you, Anjali, for pushing us and taking this initiative along with Hemant sir and Archana madam, so that now for these last 4 or 5 times, now this webcast system is working. And I think we hope that this message spreads to all students. Today, I think because of Holi, less numbers have logged in. But we hope that this message goes across and more students benefit. So thank you, Anjali. Thank you, Palgar branch. Thank you, Pallavi madam. And thank you, Hemant and Archana Joshi sir.
Thank you, everyone. Thank you, Amdekar sir
Thanks.
and team. It's excellent.
Yeah. Thank you.
So we'll meet next Thursday. Thank you. Thank you. Bye.
Okay. Thank you, everyone. Thank you, everyone.
Bye.